Hi, everyone. My name is Tom Viola. I'm the Executive Director at Broadway Cares Equity Fights AIDS, and I'm glad to be here at the FCAA conference today. Broadway Cares Equity Fights AIDS is the philanthropic heart of Broadway. We are a fundraising and a grant-making organization. And when we began in 1988 as two separate organizations, Equity Fights AIDS and Broadway Cares, that merged in 1992, we were funding essentially the HIV/AIDS initiative of the Actors Fund, which is the employee assistance program of the entertainment industry, as well as the beginnings of our national grants program, which was maybe about 50 organizations, primarily here in New York, but a little bit beginning to build across the country. We are now an organization that funds easily 473 social service organizations all across the country. In 50 states, Washington, D.C., and Puerto Rico. We're very proud of that fact. Since 1988, we've awarded over $130 million to those organizations. I've been doing this work since we began in 1988. When that began, I was indeed HIV negative and had been tested a number of times in the early 80s, proving that to be true, happily. In 1993, I seroconverted for a variety of reasons. Certainly, I was in a very difficult moment in my life that occurred. I began medications in 1998. Certainly, seroconverting in 1993, prior to the advent of antiretrovirals, was a much different thing to absorb and understand than it was with the antiretrovirals coming about in 1996. So in that way, I was indeed extremely fortunate. By the time my T cells dropped below 200, which was 1998, I was able to begin treatment, which of course at that time was difficult. It began as about 12 horse pills and changed and morphed and became better and more efficient through to today, where I literally take one purple Triomec every morning. And with that great support from science, my life continues. I'm really happy and proud to be introducing today's second panel entitled Ending HIV/AIDS in the US, a National Leadership Discussion. I'm happy to be a part of this, particularly since Broadway Cares Equity Fights AIDS has awarded over $130 million since 1988 to more than 473 social service organizations, public policy, and advocacy organizations of all sizes, the smallest grassroots organizations to some of the most prominent and largest in the country. So here we go.
Good afternoon and good evening, depending on where you are. Welcome back to the second panel of the FCAA Summit this year. My name is Julie Patterson, and I'm the director of the AIDS Funding Collaborative. We're located in Cuyahoga County, Ohio, which is relevant to this conversation, one of the phase 1 jurisdictions for the United States. So today's topic, as you heard from Tom Viola in that wonderful video, is Ending HIV in the US, a national leadership discussion. And this is the first summit for FCAA under a new US administration, and with a reinstated Office of National HIV/AIDS Policy. This session is going to give us a chance to talk about the administration's plans and priorities and how they align with private sector efforts like ours. We're going to explore some of the lessons learned from EHE here in the US, as well as some of the efforts that are going on to coordinate EHE within broader public health initiatives. And we're going to hear from both public sector representatives as well as advocates and funders who are working in the field. So I want to just remind folks as we get started of the Jamboard. You're probably seeing from the comments in the chat that we encourage folks to write their key takeaways from each one of the sessions in there. Feel free to do that at any point. It is live now. And so you know we're going to be watching both the chat and the Q&A closely during the session. They'll be feeding me the questions so I can try to keep an eye on them. And I want to say thank you to the Health Corps team that is working on that with us. I'm going to take a moment now to introduce our panelists. I'm really honored to have them here today and thrilled to be in this role with moderating. First, we have Harold Phillips, who's the director of the White House Office of National AIDS Policy. We also have Dr. Jonathan Merman, who's the director of the National Center for HIV/AIDS, Viral Hepatitis, STD, and TB Prevention at the Centers for Disease Control and Prevention, known as CDC. We have Carl Bologna Jr., who's the Vice President and Chief Advocacy Officer at AIDS United. And also we have Nana Khanna, who is the Co-Executive Director of the Positive Women's Network USA. So welcome to all of you. We're excited that you're here and really grateful that you're joining us today for this conversation. I wanted to just let folks know that what we're going to do first is go around and let everyone have a few minutes, about 5 minutes, to offer remarks, and then we'll begin our dialogue. We have a number of questions that we can talk through, but as I mentioned, we're also interested in hearing from our attendees. So first, I'm going to turn it over to Harold, if you don't mind. Thank you.
Sure. Thanks, Julie. And thank you all for inviting me. And thank you to the funders who've been so committed to helping us end HIV and AIDS and the work that you all have done in the past. And I'm excited about the work that we're going to do in the future. As Julie said, my name is Harold Phillips, and I serve as the director for the White House Office of National AIDS Policy, an office that was reinvigorated, I would say, and reconstituted under the Biden-Harris administration. And we started work in early June of this year. So it's been a very busy time in this new role. Previously, I was with HHS as the Chief Operating Officer for the Ending the HIV Epidemic Initiative. And as many of you all are aware, EHE, which was the funding for EHE, came through, and we began sort of making awards very early in calendar year 2020, and then along came COVID-19. And so we had the HIV epidemic, we had COVID-19 going on, we had federal workers having to learn how to work full-time from home, as well as the rest of the world. We had numerous strains on our public health system. And so the past 18 months have been full of challenges, but also full of opportunity. And we have seen how resilient and dedicated and creative that the HIV community is when it comes to continuing to ensure the integration of prevention, care, and treatment services for the people in the communities that need them at most. We've also seen through President Biden and his budget request that ending the HIV epidemic remains a priority. He has requested in this year's budget $670 million for the initiative. And in that request, he also called for us to accelerate and strengthen the effort to end the HIV epidemic in the United States. So we'll be continuing both our geographic focus as well as working with our stakeholders to re-engage and re-energize our national HIV response. One of the other things that I'm doing is working to revise the national HIV/AIDS strategy, which will serve as our framework and outline the priorities over the next several years as we look to innovate and accelerate our response. It also calls for us to address head-on the challenges of the health inequities that continue to be a challenge, and also to address structural and historical racism, which perpetrate the inequities that we see when it comes to HIV. So that's just a little bit, and I'll turn it back over to you, Julie.
And I'll turn it over to Jono. You're the next one. Thanks.
Well, thanks very much. Thank you. I really appreciate, Julie, you inviting me and setting up such an outstanding panel of friends and leaders. I believe that HIV funders can continue to change the world, either by filling in gaps where resources are most needed, or by exploring new territory where others fear to tread or are unable to go. So I wanted to take this brief introductory opportunity to highlight some specific areas where I believe support would be particularly impactful, And I'll focus on the US because there are other sessions highlighting global opportunities, but many of these will cross the international divide. So the first is tackling communications, especially in the digital world. COVID-19 has made our life harder, with large forces like social media and political rhetoric exacerbating distrust in institutions and people. And this has resulted in increased skepticism of traditionally generally trusted institutions and people, such as the CDC or healthcare providers and community leaders, and health interventions like vaccines, the very things that we need in the response to COVID-19 and whose success requires trust. Yet it is the internet that most influences our lives, not only negatively, for example, by promoting false conspiracy theories or incorrect statements about PrEP, but also positively, whether micro-targeting products or changing support for social movements. As we all know, from having shoes or a gadget we were looking at suddenly being shown to us for several days as clickbait across multiple platforms, and Google and dating apps can bring information to the people who need or might want it. And so how do we ensure that information on easy access to HIV testing or PrEP is being brought to the people who need or want the most? How can we ensure that people with HIV are informed about U equals U and or a gay-friendly provider in their area? And the day and age of vague advertisements on national TV or billboards or bus stops has ended, but we need help with our future. The second point is supporting networks of people with HIV. There are about 1 million people living in the US who've been diagnosed with HIV, and we've embraced the idea of empowering our HIV decision-making and actions with real involvement, leadership, and collaborations with people with HIV. And that includes people with HIV in powerful governmental leadership positions, whether the current director of the White House Office on AIDS policy or the prior director of CDC's Division of HIV Prevention or a division director at HRSA, heads of HIV community-based organizations or health departments or think tanks or funding organizations, or membership in federal, state, and community advisory councils. When we look around, we are often working alongside well-known friends and activists and scientists with HIV. However, there are many communities of people with HIV. HIV intersects in different ways with our identities and our experience, and we need organizations like NANA's and others to support people with shared core experiences. And overall, only a small proportion of the 1 million strong are involved in a PWH organization, perhaps because that type of engagement is not the thing for everyone, or maybe because the networks themselves have not been fully supported. The US People Living with HIV Caucus is an overarching umbrella organization that supports other organizations of persons with HIV and shares information and is engaged in activism. And I think all of us need a gateway for input and insight into programs and policies when they are needed the most. We know well from our work with HIV to succeed, we need to actively work with the communities most affected, implement interventions with community members and organizations, and do a good job. And in HIV, we have seen some success in reducing incidence by over 75% since its peak in the mid-1980s. And we've seen some partial reductions in the most glaring disparities, including reduced incidence among young African-American gay and bisexual men and African-American women and persons who inject drugs. This was done by working with HIV communities to provide resources aligned with the burden of disease, ensuring resources were used for the most effective interventions, and working with the research community to get us the tools that really work. So I believe to truly achieve rapid progress in health equity, to meaningfully move the nation towards ending the HIV epidemic, and to do justice, we will need to do more to support organizations of people with HIV. The third is policy. In an unjust society, health disparities will naturally occur without concerted intervention. And this is what we saw within a few weeks of the COVID-19 pandemic, and they continue today, albeit to a lesser extent. Gaps in HIV prevention and care are created and exacerbated by non-supportive policies that indirectly cause HIV infections and prevent people with HIV from reaching their ultimate health. There also can be in our policies and laws that support HIV prevention in people with HIV. We need to change or remove the ones that cause harm and implement new ones that work well. And there are numerous examples of these, such as the syringe service programs, which have been proven to be effective at preventing HIV and hepatitis C, and yet they are not legal in many jurisdictions. We have well-documented HIV outbreaks currently occurring in places that have stopped SSPs or made them difficult to access. And there are limits to the support federal funders can provide for SSPs because currently most federal funding cannot be used to purchase sterile injection equipment. Other examples are the positive impact of civil rights laws that prevent discrimination against LGBT populations, or the negative consequences of HIV criminalization laws, or redlining policies that exacerbate racial injustice. restrictions in some Medicaid plans on covering PrEP. Policies matter because they often have long-reaching arms and can leverage entire systems, but changing them doesn't often feel as tangible as running an effective community-based program or providing care to patients. But I believe sometimes bureaucracy matters, and we would do well to use policy as a public health tool. And my last point is that place and people matter. We should put our money where our epidemic is, whether by geography or population. Approximately 2/3 of new HIV infections among African Americans or Hispanic Latinos in the nation are in the 57 EHE phase 1 jurisdictions out of over 3,300 counties in the United States. So EHE has worked to support local community-driven solutions, as Harold highlighted, including, for example, having CDC require that at least 1/4 of EHE recipient funding go to activities implemented by CBOs. So in EHE, if we do a good job, we will also increase equity. And this can be at a large scale or small, investing in services that ensure people with HIV and populations disproportionately affected have ready access to things like transportation or housing, childcare, mental health treatment, or jobs. And we will do good if we do that well. So I want to thank all of you who are members of FCAA. Keep putting people first, especially the people who are most affected by HIV, focusing on equity, putting your money where your epidemic is, leveraging policy as a public health tool, and prioritizing innovation. I'm reminded of how we responded to AIDS in the beginning, as Simon highlighted in his video. We did not wait for highly effective ART or PrEP. Instead, we took immediate action to support each other and change the future. And if there's a message from that, it is to care for our communities and ourselves. So thank you.
Now to Nana for your chance to make remarks. Thanks.
Great. Thank you so much. Greetings. I'm Nana Khanna, she or they pronouns, co-executive director of Positive Women's Network USA, and also a member of the U.S. People Living with HIV Caucus. I want to really thank funders concerned about AIDS for having us here today. And also our federal partners for your work and your leadership every single day. We are here to partner with you. And I want to thank our entire audience and all of our philanthropic partners for your commitments to address equity in the HIV response, and particularly for the increased focus on racial and gender justice as core to addressing the epidemic. I come to this work as a woman living with HIV. I was diagnosed in 2002. I also come to this work as the daughter of immigrants, as a person who has an embedded lived experience and embodied lived experience in a lot of different communities of color. And I think that it is critically important that we recognize this moment in 2021 as a moment of opportunity. We have a new administration. We have incredible federal leadership on the HIV response. And so we have a small window of opportunity to really make things better for our people. But what we know is that actually things are often getting worse. Racism, transphobia, discrimination, the ongoing COVID-19 pandemic, our communities are suffering. People living with HIV, it's no secret that people living with HIV in the US are primarily people of color, primarily Black folks, Latinx folks, queer and trans folks, people who are marginalized and structurally harmed by many systems that should be taking care of them, whether we're talking about housing, healthcare, the safety net, criminalization, and policing. There are so many different ways in which our communities are being harmed. And so at Positive Women's Network, we view HIV not as the actual problem, but as the symptom of many different systems of inequity. And so that's what we ask our community to embrace with us, is real long-term structural solutions that will lift our communities up so that when the next epidemic happens or the next pandemic happens, we have a robust, strong safety net, we have human rights protected, we have dignity and equality protected for our people. I want to talk a little bit about people living with HIV networks and what makes us different from just working with individual people living with HIV, and what networks are, because sometimes they're more well understood in a global context. So Networks of people living with HIV are basically organized formations created by, led by, and accountable to a constituency of people living with HIV. In the US, we have an estimated 1.2 million people living with HIV. Networks are vehicles through which we, as people living with HIV, can define our own agenda, choose our own leaders, and speak with collective voices. And the US People Living with HIV Caucus, which was mentioned previously, includes the global network of people living with AIDS, the international community of women living with HIV, the National Working Positive Coalition, Positively Trans, Positive Women's Network, the Reunion Project, Zero Project, Thrive SS. It's a very robust and diverse group of stakeholders that are represented. We collectively represent many of the communities most impacted by the epidemic in the United States. Our constituencies are organized around race, gender, age, gender identity, sexual orientation, immigration status, and we work collectively on issues that impact us. We bring a unique lens that is informed by lived experience to advise on policies that will improve healthcare, quality of life, quality of treatment for people living with HIV. And as people living with HIV, we also understand HIV-related stigma, discrimination, structural conditions, racism, homophobia, sexism, transphobia, ableism, poverty, xenophobia, so many of these different systems in direct embodied ways. Many of us are also involved as service providers, or as people who are developing and leading programs serving people living with HIV. Many of us have built community-based organizations and advocacy initiatives. We are in direct contact with tens of thousands of people living with HIV across the country. So while we might not have access to all 1.2 million, we are easily able to take input from and kind of vet priorities and what's going on in real time with many people living with HIV through mechanisms for community input and consulting with folks. And so as the epidemic has become increasingly biomedically focused and our response has become increasingly biomedically focused, one of the concerns that people living with HIV have been uplifting is that we must address quality of life issues for people living with HIV consistently. We must have real dedicated structural solutions that will outlast any particular federal leadership and any particular administration that really protect our people. I think we all saw what has happened to our communities over the last few years. We cannot have a repeat of that again. And so our ask of federal partners and ways that you might see us pushing you is really about partnership. We're asking you to help us create a safe, long-term container for people living with HIV who will still be here once the epidemic has ended. We will still be here living and thriving, with your partnership and your leadership on ensuring that our communities are protected. And so we have got to address this epidemic from every single angle. And the Demanding Better agenda, which the U.S. People Living with HIV Caucus has put forward, is the first time that networks of people living with HIV nationally have come together to create and put forth an agenda that collectively represents our vision for safety, dignity, liberation, and human rights for people living with HIV. And it starts with creating an affirming human rights environment for all of us. It starts with real, robust, meaningful partnership with people living with HIV at every level of decision-making and policy. And it ends not when our viral loads are suppressed, but when we are thriving and surviving, whether we have HIV or not. And so that's the vision that we put forward to you all, and very much looking forward to this conversation today. Thank you.
Great. Thank you so much, Nana. Really appreciate that. And then Carl, we'll turn it over to you for some introductory remarks. Thanks.
Thank you, Julie. I'm Carl Bologna. I'm Vice President and Chief Advocacy Officer with AIDS United. And AIDS United is a national nonprofit with the sole mission of ending the HIV epidemic in the U.S. We do our work through strategic capacity building, strategic grant making, and policy and advocacy. And I think our true power, we envision ourselves as being the conveners in the sector, and our true power comes from our members of the Public Policy Council, our grantee members, and our capacity building assistants folks that take advantage of those resources. I'm proud to say that Nana Khanna with the Positive Women's Network serves on our PPC as one of our members, and our power as conveners and the power that we derive from the folks who are in communities across the country, be it from our 56 plus PPC members, our nearly 300 grantees across the country, or where we derive the knowledge around what it takes in the epidemic in each community across the country, the political will to build power with policymakers so that advocates from across the country are heard, is so impactful and so meaningful to me and to the work that we do. I think every day about the power that we hear from folks like the Positive Women's Network, from members at Crescent Care in New Orleans, from San Francisco AIDS Foundation, and really hearing their community's experiences and how we can work together collectively to address the needs across the country. I think Jono said it best about expending resources where they're needed, put our dollars where the need is, and that can't be more true today than ever. I think about 18 months ago, I think, when this epidemic started to get very real for all of us across the country, and we were looking at moving AIDS Watch, which I think many of you are familiar with, from an in-person event to a virtual event. And I reached out to Dr. Merman for advice on what to do. And, after our conversation, it became immediately clear that what was most important was protecting the lives of our community, the lives of AIDS Watch attendees, and making sure that we still created a safe space for them to gather and network and share experiences. And, AIDS Watch is an event that, as I mentioned, the way we do all of our work is a community effort. It's with AIDS United, the U.S. People Living with HIV Caucus, and the Treatment Access Expansion Project. We spoke and we decided to form an agenda that reacted to what was happening in that time to address COVID-19 and the disparities that were being highlighted and that have continued to be highlighted over the course of these past 18 months. It's been such an interesting time. Not only have folks been managing their HIV or working to remain HIV negative or just live safe and healthy lives and remain COVID free. But, this pandemic has shone a light on existing disparities that we've all known about for quite some time. The same populations of lower income or Black and brown folks have been disproportionately impacted by COVID-19, have faced increased levels of vaccine hesitancy due to misinformation or very legitimate medical mistrust because of historic instances of medical mismanagement of those populations. And so I think, now that we are almost 2 years out and we are starting to think about gathering together again, it's really important to continue to learn from this experience to really chart a course that'll have more sustained and impactful change. I know I'm kind of doing a bit of reminiscing right now, but, Ursula, early in the epidemic, we were forced to grapple with, aside from COVID-19, our nation's history of racial injustice and inequality after the murder of George Floyd. And what became immediately clear is that this is so pervasive across all that we do that we can't cure our nation's problems. We can't cure HIV. We cannot prevent new infections unless we're touching communities and are fighting against systemic racism, systemic challenges that are preventing access to care, treatment, and just folks' ability to live whole and healthy lives and safely in their communities. So I'm really thankful to be here with each of the panelists to discuss the challenges and the opportunities in front of us to end the epidemic today. So thank you.
Much, Carl. Really appreciate everyone's introductions. And I think now we're going to take a few minutes just to begin our dialogue. It'll give folks who are watching today a chance to enter your questions into the Q&A. So feel free to do that now. But I'd like to kick us off with a question that springs from something Jono mentioned. You talked quite a bit about something as kind of your fifth point that really resonated with the work we've been doing, which is this idea that place and people matter, looking at not just the networks, but also the neighborhoods, the geographic areas that are most heavily impacted by HIV. And I thought that perhaps some of the other panel members might want to weigh in on that sort of concept as well around place and people matter. I don't know, Carl, you were just talking. Is there anything that resonates for you with that?
Sure. I think we've experienced and we've learned so much about the epidemic from the start. Obviously the epidemic had its biggest strongholds in the New Yorks and the San Franciscos of the country, and it's moved southern, it's moved more rural, and it has. I've seen the lost video. Do I have everyone? I'm sorry, Julie.
No, you're there.
Okay.
Yep, that was good.
Apologies. It has simply shifted, and we've learned that the allocation of resources really matters. That resources are hitting communities that need it the most. We, as advocates, have worked really hard to help focus those resources where needed. We've had successes through modernization of the HOPA program in 2015 to make sure that cases are reflective of where the community's need is. And that can continue to be increased. So thankful for the administration, past and present's focus on ending the epidemic in the U.S. So thankful for the focus on the 57 jurisdictions. But it's also really clear that it's important that we focus on the whole epidemic and reach pockets across the country that are still being left behind. As I mentioned, the racial and ethnic disparities, language barriers. It's really important that we still focus in on where people are being impacted and where we still see spikes outside of not only the 57 jurisdictions.
Great, thank you very much. Thanks. I was thinking I saw Harold was trying to say something. Was I right or no? Can't tell.
Well, I could, Julie. Thanks.
Okay.
I think, in addition to focusing on those areas of the country where we have the greatest disparities when it comes to HIV. So as Carl mentioned, thinking about the southern United States, the western areas, thinking about some of those issues that we've talked about as the social determinants of health. One of the things that we've done at the national level is try to engage other programs from other federal departments and agencies. Our colleagues in HHS, and Dr. Merman being one of them, does fantastic work sort of applying both the federal resources we have, but also ensuring that we are able to use the best in terms of science and innovation and implementing these at the local level. But we also need the resources of federal programs like those from the Department of Agriculture and Education and Labor and housing outside of what HUD does. And so part of what the ONAP office has tried to do is engage those other programs as part of our HIV response by having them participate in the redevelopment of the new national HIV strategy and understanding where they fit in and where they can work. Because in many cases, they're already working in some of these communities and implementing programs such as public housing and dealing with some of the issues like income insecurity. And so thinking about that from a people-centered HIV lens has been really what we've been trying to do as we're working toward the development of implementation plans that include those programs and agencies.
That's great. Thank you. And Nana, I was thinking local, when I think of PWN in the US, I know that local means a lot for you with local chapters. Are there any reflections you have on that idea of places and people matter?
Of course. Yes, absolutely. Well, as you might know, in addition to our national membership base, we do have chapters, and we very intentionally have resourced investment in the South in particular for the last 10 years, where more than half of women living with HIV, and particularly Black women living with HIV, are residing. And I think that this is, again, where it's really important to talk about context, because these, what's happening with HIV incidents and health outcomes for people living with HIV is not happening absent a larger context of anti-Black racism and segregation that's been going on for decades, if not centuries, and a fracturing safety net, and politics where sexual health and reproductive freedom are political footballs, and multiple states where anti-trans legislation is being proposed and passed, and where critical race theory is coming under attack. And so this is the context that people are living and working in. And I think many of us as people living with HIV would say that even as we're seeing a trajectory of HIV incidence numbers go down in ways that are very positive, things are actually getting worse for people living with HIV, because people living with HIV have been forced into a lifetime of poverty because of the way our systems and our capitalist structures have been set up for a very long time, right? So now we have the Affordable Care Act, and we have in many places Medicaid expansion. But for decades, it was required that people living with HIV had to be poor in order to access medication in the first place. And we still have these income eligibility caps on programs for housing and other types of services that folks are relying on to survive. We just successfully fought back an attempt to kick about 2,500 people in Texas off the ADAP program due to some budget issues. So these are not old problems. These are new problems that we're facing. And so, and these are persistent, ongoing issues. So I think that, yes, place absolutely does matter. And we have to focus on creating stronger containers in those places and using the levers that we have within mechanisms like the Ending the HIV Epidemic program to think about how we incentivize structural reform in those places, and how do we tie it to resource allocation for those places to actually create a better environment for people living with HIV and communities most vulnerable to HIV.
That's great, thank you. And it has me thinking along the lines of something I saw come through in the Q&A. Amelia was asking and sort of really pointing out that we need to open up resources for the grassroots response. So the language around local maybe even should be hyper local. And so I think it's really valuable to be talking about the jurisdictions under EHE. And also I think as funders, just bringing it back to FCAA, at least some of the folks, including myself, are funding on the local level. And I'm just curious if you all wanted to offer insight on sort of how the best response we can have to be in partnership with what's happening on the local level from EHE. I think that might be a Harold question.
Well, I'll go, and Dr. Merman may also want to chime in. One of the things that I have appreciated both from my time in OASH and also my time in the White House is when funders will actually sit down with me and talk to me about what they're thinking, and also my ability to give them perspective on what we're thinking and planning. Because of the way our crazy government system works, we're already in the process of thinking about what fiscal year 23, which starts in the fall of 22, is going to be. And so we're already thinking about the data that we currently have, the gaps, and what programming might look like come fall of 22, calendar year 2022, which is our federal fiscal year 23. So we already have that idea. So I really have appreciated it when funders have been able to come sit down, have conversations about what they're thinking and where they're thinking about sort of placing funding priorities in which communities and which populations. And I'm able to sort of share with them our data, and as much as we're able, also share what we're thinking about in terms of funding and where we're thinking about going with our direction.
If I could add, is that okay? Can I?
Yeah,
so,
yeah. Please.
This is just a great conversation. I had two thoughts about this. I mean, one is that we were proud of something that I am now not as proud about. And that is about a decade ago, we shifted our resources that CDC provided health departments to match it to the epidemic. And we focused on the most cost-effective, and often actually mostly cost-saving interventions. And we had large reductions in HIV incidence because of it. We also shifted large amounts of money more to the South, as Nana had talked about, because that had not been appropriately funded. And so I'm very proud that reduced by about 18% the incidence of HIV. That saved a lot of, of hardship for people. But then I realized that if you just match to the epidemic, you're not decreasing disparities. You're maintaining them because you're funding about the same to the epidemic. So we have now recently developed a concept of super proportional funding. Like if you want to decrease inequities, you have to give even higher amounts than what would be proportionally provided to jurisdictions and communities to be able to reduce even more, because they deserve it and that's what they need. And I think the idea that we can shift resources so it becomes available is important. So if we do this well, suddenly the local communities that really need it and the populations who often are virtual, right? I mean, transgender women in the nation live everywhere and can be reached through ways that are not only physical. And the same thing would go for anybody. And I think that if we can think about how do we make the money available so that the communities organizations can reach up and get it, or if you're a network of people living with HIV, you also can have access as a population. And sometimes a funder yourselves. And then the other is that I work for the federal government. It's really hard to deal with our bureaucracy, both internally and externally. It's hard to, and I think that, but a lot of the funders in this meeting, they work local. You really can have small grants. AIDS United has an amazing syringe service program where they provide resources to small organizations, and a lot of organizations can do that, and in a way that we can. So if we can get resources available to these others, or if you're a funder and you have access, I would say do the right thing. Make sure that you're not funding things that aren't helpful. Think about context, but also that you have an opportunity working in the hyper-local environment that is more likely to make a difference, because you're more likely to be able to adapt to the needs that people have right then and there, and not just generalizing what everyone needs across the country.
Thank you so much. And I see there's another question coming in, but I have to take this opportunity, Carl, just because of the reference to the work of AIDS United. I know that FCAA has recently put out that really helpful report talking about what it means to be a community-rooted funder. And I think Jono's really, pointed out that AIDS United is very much funding on the ground. I'd love for you to talk about sort of what it means that we're seeing policy on the federal level around syringe service programs, not for the first time, but in some ways in a really amplified way. How is that impacting the work you all are doing with these small local groups, the local syringe exchanges, et cetera?
Absolutely. We're thrilled at the opportunity. It is a bit like Groundhog's Day. We've seen the federal banner on syringes be lifted and come and go and back again. That being said, the resources that we have received from the CDC and from private funders as well to support local SSPs has been tremendous. For those organizations, those local programs, even a micro grant of $10,000 can be so transformative to the way they can serve their communities. And, through the lockdown, but unfortunately, SSPs were not deemed essential services. Many were forced to shut down and leave their populations without support and without care. I also wanted to kind of touch on the hyper-local piece about things that funders can do is really drop the unnecessary barriers to requesting funding, make it as easy as possible, include translation services, or translated documents in multiple languages, at least that are, aligned with the populations and the communities that you hope to serve. But I think that's one of the key barriers that is really, frankly, rooted in white supremacy, is having onerous barriers to grant applications that don't get at the spirit of what the funding is meant to do. I think that AIDS United has done a good job. We can always do better to accept applications over the phone, by video, and just exploring continuous ways to decrease the hurdles that folks and organizations face.
Great, thank you so much. I want to take a moment now to ask one of the questions that came in the Q&A. So Kathy from VIV has said that she's so moved by Carl's description of the deep systemic issues that affect this epidemic and the pandemic. How can the learning from the U.S. guide the global response? I don't know if anyone wants to start with that.
I'll just,
Oh, go ahead,
I can just
John.
say one brief thing. I lived and worked in Africa for 10 years on HIV, and I think it's a multiple engagement process. It's not a single direction, and I'm sure that Kathy agrees. It's you learn from each other's experiences, but sometimes what happens is the countries deal with country level stresses. They deal with politics. They deal with but everything that's, Uganda has to deal also with massive disparities in wealth and what we would call racism within their country, even though it's usually based on tribe, and sexism and horrific homophobia and transphobia. And yet there are people who want to do good within that environment. And the question is, how do you do that? What kind of decisions do you make to try to make sure that I'm learning about changing policy, doing things even if you don't change policy, trying to figure that all out. Sometimes at both the high level and the local level, your closest partner is someone in another country who's doing exactly the same thing. Just like I think people who have HIV think that sometimes I can bond most with someone and learn from someone else who has HIV, even if they live in a different country. And the same thing for a funder or a community-based organization, and that's kind of a network. And so I do think there's lessons to be learned and exchanges, and I could come up with some examples if need be, but I think people can know them. But there's a bunch where we've learned in multiple directions, and keeping that avenue of communications and learning is important, including in the research arena.
I was thinking, thanks, John. I was even thinking also of Nana, of your remarks when you started talking about the partnerships that cut across all these boundaries, where you mentioned so many folks, even in what's called the U.S. People Living with HIV Caucus, to have all the global partners involved. And I was thinking of your recent work where it's HIV Justice Worldwide, right, that you've partnered with. So maybe, would you like to reflect on that one?
Yeah, I think just to sort of pick up on Dr. Merman's comments, I think it is, I think it's always important for us to be mindful that the U.S. has a history of exporting a lot of harm, not just good models. And just a few examples of that include HIV criminalization laws, the global gag rule, anti-prostitution pledge. These are all things that the U.S. has successfully exported all around the world that have actually harmed some of the most vulnerable communities. I think that the same principles that apply here apply anywhere in terms of how we respect Indigenous knowledge and understanding, prioritize long-term investments in communities that are most directly impacted. And kind of use that to drive change. I think there are a lot of opportunities for collaboration, rich and deep collaboration in that arena. I would also say that there's a lot for us to learn from other countries in terms of how civil society, for example, is involved in their responses. So through the country coordinating mechanisms that are funded by PEPFAR, for example, it's actually written into a number of those mechanisms that PLHIV networks are part of the civil society groups that are core to kind of deciding how the HIV response in that country plays out. So for example, what that could look like here is having designated seats for the U.S. People Living with HIV Caucus on PACHA and on CHAC, where the U.S. People Living with HIV Caucus actually designates its own representatives to represent the PLHIV community in meaningful ways, in advising on strategy, in monitoring and evaluation of the national HIV response. These are models that are being used in other countries that we can also adopt and learn from.
Great, thank you. We had a couple questions that have come in related to health departments. And so this may be a Harold question. Let's see, the first one is really talking about how can we break the bottlenecks at state health departments that keep resources from reaching the most impacted communities? And maybe even weaving in the second one a little bit about that Robin asked from Greater Than AIDS, funds that are going to buttress health departments and what gaps in workforce and other capacity building can philanthropy support? I don't know, maybe they don't necessarily go together, but see what you think, Carol.
So let me try on some of this. So within the National HIV/AIDS strategy, we are talking about the importance, has been mentioned on this panel, of engaging those with lived experience, both everything from planning to service delivery to helping inform policy and shaping our direction. Also, the administration is working through OMB to figure out what are the other tools that we have at the federal level that can be used to better target resources across the federal government to communities most in need. And so I'm waiting to see what comes out of that report and see if there's anything that we can begin to implement and think about differently when it comes to our HIV federal resources. So I guess with that, I'll turn it over and see if there's anything Dr. Merman wants to add that they may be thinking about. But I think as we also think about both sort of how do we accelerate the response and how do we target those resources to the communities most in need, we are exploring other avenues. I know one of those avenues that we've at least had some informal conversations are about sort of those private sector funders and the ways and the abilities that both they can include in their funding announcements, things that we can't include in our at the federal level, but also the ability to move quickly. And so how do we create additional sort of private-public partnerships that might enable us to move around some of those bottlenecks?
I agree with everything Harold said. I also was curious about the question, who is we in this question? But I would say that in terms of what funders in the community can do, bring attention to the important issues. People respond, especially people in government, are quite responsive frequently to attention. And the other is jurisdictional planning. And I mean, certainly for CDC and HRSA, we have a joint plans from jurisdictions. We now have EHE plans for local counties, and they matter. And the decisions are made about where resources go. I will say there's a variance in how the health departments respond to those, and that is an area that we can do better with, in turn to ensure that where the money goes is aligned with some of this. But being membership on those planning committees and highlighting what really does work and make sure that people have kind of a justice perspective as well as an efficacy perspective will be helpful. And then the other side I would say is at the policy level. If we is at the federal, state, or whatever level, I mean, it's very hard to be a sex worker in America, as Nana had highlighted. It doesn't have to be that way, right? And I think it is an issue for HIV prevention. There's other policies, whether it's Medicaid expansion, coverage of hepatitis C treatment, PrEP access. There's a variety of life-saving tools that are not available because of the policies that are in place, sometimes at the state or local level, and sometimes at the federal level. And I certainly can speak for Harold. He reads the documents. I mean, I read the documents we get. It's like we read them. You don't even have to pester us. We read them, and they do influence. We think about them. We argue with them when you're not even in the room. We think about, is this true? And then we often change what we are doing in response to that. One example I'll bring up is about 10 years ago, I met with at USCA. I met up with a transgender group that was arguing for better surveillance data. So we had basically a decade of improving our data. We changed our case report form for HIV. We now have not only do we have a special surveillance supplement on HIV among transgender women and men, but we actually now have it incorporated every year into our data. We have special studies, because sometimes you need special studies to get accurate data on smaller groups with smaller numbers. We did that with NHBS, and we've been able to kind of really change how we are acting. I also would say now we have enough information that we should concentrate on action. So we have a cooperative agreements that specifically funds CBOs that work with transgender persons of color, but we also are thinking of how do we expand that to be more effective, because it is harder to reach with services because the environment is different throughout the nation, but we need to do that. We can't be intimidated by difficulty. And so where did that come from? It originally came from activists talking to us, and we continue to be as responsive as we can be.
And so if I
go ahead, Nana, please.
hop in a second. I want to underscore, I think, some of what's being lifted up, which is that it's really important to continue investing in advocacy. This work cannot happen without resourcing advocacy and community organizing year over year. Philanthropy will never be able to fill the gaps that the government needs to be filling, whether we're talking about state, federal, local government. These, housing, healthcare, food, these are things, education, like these are things that are just a human right that we need to be able to codify into law and policy as human rights. And the only way we can do that is with sustained advocacy. So unfortunately, HIV philanthropy has been kind of starting to move away from resourcing advocacy work. And we really need your partnership to help keep that up. That's how we break the bottlenecks at state health departments. It's how we actually help state health departments. There are a lot of great people inside those state health departments who just don't have all the information or are dealing with their own bureaucratic systems, to be able to get the resources out to directly impacted communities. That's where we come in. That's why it is so critically important to support leadership by Black and Brown folks, people living with HIV, queer and trans folks living with HIV, sex workers, immigrants, all of the communities that are historically marginalized from decision-making processes. The answers are always in the community. We just have to resource the community to help provide those answers.
If I may,
please, yeah.
It's a comment that I think deserves an amen. Advocacy dollars are the hardest dollars to fundraise, frankly. And I appreciate Dr. Merman for actually sharing the impact of individual advocacy that he experienced had on federal policy, on how the CDC reacts. So case in point, advocacy works and makes meaningful change. And in the case that Dr. Merman mentioned, supporting a population, trans folks across the country that are so marginalized and face some of the greatest hardships among our community. So yes, more advocacy dollars.
Yeah, and actually that's echoes from this morning. The panel earlier that was on pandemic preparedness and response very much had the same message, that advocacy funding is really needed. And so I think when we talk about the dialogue, right, between what's happening in the US response and the global response, it's very much on the same page. So thank you so much for the great comments. I wanted to just also offer an opportunity for people to answer kind of a question about bright spots, I think is the phrasing, or causes for optimism that you see in the response. And this can be, obviously the federal response right now, but also in what folks have referenced in terms of the number of key advocacy documents that are out here and forming. So you're each welcome to offer a bright spot or a number of them. I saw some head nodding. Jono, did you have a thought right away, or?
No, go ahead. I'll
Oh, okay.
follow up with others.
So, as the ending the HIV epidemic cheerleader, I will say that I have seen some bright spots, and I think this also ties into the question about sort of the global piece as well. I mean, we've seen in the last 18 months greater use of HIV self-testing in this country, which has been, overseas for quite some time. That's a huge bright spot. Our expansion of telehealth and the delivery of HIV prevention, care, and treatment services through telehealth. Multi-month prescriptions are another bright spot, something that I have wanted done for quite some time. We've seen that sort of take off more. I think that we are, another bright spot are the conversations about race and its impact on HIV. I think there's a greater understanding given all that we have been through. Also, I think greater understanding and appreciation of the intersection of trauma and infectious disease. So I think we're at this important juncture where there is greater understanding, and we are at least trying to figure out how do we apply these tools that we have to prevent new HIV infections, as well as treat those living with HIV. Another piece of a bright spot where I think the advocacy community has really come through loud and clear to us at the federal level is around quality of life for people living with HIV and those that are aging with HIV. You're going to see and hear more about this in both our strategy and our implementation and trying to address these issues. And I think that as I think about sort of bright spots, it's remarkable to think about at 40 years, we're at this point in the HIV epidemic where we're talking about quality of life. We're talking about life for people with HIV and how to improve that quality of life and how to help them age gracefully and HIV across the lifespan. And so while I don't necessarily have answers to that, I'm so grateful that that's where we are in our response, not only in our nation, but across the world. And know that by working with the community to understand, we will be able to develop the answers to some of those pieces.
And if I now, Julie, if I could, it's too exciting not to. First of all, it is a hard time to be talking about bright lights because things are still really hard. But I would say there are three things that really strike me. One is something Harold raised, which is the explicit discussion of racism, homophobia, transphobia, and how it affects what we are doing is now deeply embedded in our work and our communications internally and externally of the federal government. I have never seen it that way. And I think it has freed many people to be able to not only talk about it, but do things differently. So we are now producing and working out how do you monitor trends in disparities over time in a scientifically accurate way. We've touched on it, but now we're fast tracking it. Our workforce, we have a whole equity plan for our center that is focused on also examining the data about our workforce and then doing a better job of hiring and promoting and having an enabling workforce environment. And because we think external public health and internal workforce are related. A second issue, I think, is that the amount of money that went out for COVID is extraordinary for a public health issue. And I think when the amounts that we are talking about are somewhat different than we used to be. And that means that if tailored correctly, there could be collateral benefits to HIV prevention and care as well. And then my third is really the idea that science and technology matter. It's been remarkable to see the success of antiretroviral therapy as treatment and PrEP as prevention, and that and now we're moving down long-acting agents. I mean, they do matter. They make it easier for people to survive and to get their job done. But we learn about our gaps by being ensconced with the community. Where are we having obstacles? What is happening that's preventing people from getting everything done? And then that feeds into the research that needs to be answered to make it easier for people to do things. And I think that relationship that we talked about a little bit earlier between thoughtful activism, not all activism is thoughtful or good, but thoughtful activism gets, and a collaboration with science and policy, and then the need from others who are making large-scale decisions about money or policies to be dealing with advocates and communities and learn about what are the problems we're trying to fill. That engagement, I think, has been strengthened during COVID. I think we are engaging more, and some of it's the virtual environment in a weird way. You don't have to travel somewhere to talk to someone, but some of it is just that I think it's been more explicit about the ability that you have to do that if you're going to do a good job. And in many ways, as people know, the HIV community kind of spearheaded a lot of this.
Very much, very much. It looked like, Nana, did you want to weigh in on that? Or the bright spots or?
Sure, I can. I think I would really echo that it's a difficult time to think about bright spots. We have people living with HIV who cannot make over like $881 a month. And that's just unconscionable. Imagine trying to survive on that in this day and age. But that said, there are bright spots, and some of them are the way that our own community has come together in response. The HIV community has always been innovative and strong and not afraid to pioneer and speak truth to power. And I think that's some of what the bright spot continues to be, and we must not shy away from that. So We've had, funders like AIDS United who have really drastically reduced reporting burdens, made it a lot easier for smaller grassroots groups led by directly impacted constituencies to get resources to do the important work that is needed in their communities, and trusting them to do that work and sustaining the work year over year. Models like the People Organizing Positively program and others, I think, are just really incredible and need to continue to be resourced. And those are the kinds of practices that philanthropy can continue to adopt that will help that will help us move forward, and especially helping organizations respond in moments of crisis. We have been in crisis for almost 2 years and continue to be in crisis, where the very survival of our people is on the line. And we've unfortunately lost a lot of folks along the way in our community. I think another bright spot is what we're seeing with the HIV decriminalization movement. If you have been paying attention, you probably noticed that in 2021, we had more victories on state level HIV modernization efforts than we ever have before. That's not because 2021 was a magical year. It is because folks have been organizing and resourcing this work for 5, 10, 15 years, to make these kinds of achievements possible. We had Virginia modernized this year. We had Nevada modernized this year. We have a lot of other states kind of on the brink of decriminalizing and modernizing these laws that basically are completely outdated and based on misinformation, and they are actually institutionalized stigma that harms our community and will make it impossible for us to ever end the epidemic truly. And we saw immense progress on those because of the kind of work that has gone in year over year into resourcing those efforts. And now we have a bunch of other states that might be prepared to modernize or repeal in the next couple of years because they've already been laying the groundwork for 4 or 5 years. These are not laws that change quickly, especially in places where communities are most impacted. But folks have been organizing in Florida and in states like South Carolina, and in states that don't even have explicit HIV criminalization laws, but where people living with HIV are still being criminalized, like Texas. And just this year alone, we had to defeat 2 new proposals to criminalize people with HIV more in Pennsylvania and Texas. And we successfully organized and defeated those. And when I say we, I mean a broad community of advocates, people living with HIV and allies who have been fighting for human rights for a long time. And that is possible because, again, of sustained years of supporting grassroots advocacy. So I think those are some of the bright spots we see. I think we have a bright spot in our federal leadership. Look at the representation we have here on this panel. We're truly lucky to have these partners in federal government working with us. And I think, our job also as community and as philanthropy is to make sure that they're supported to take what we can from this moment. We don't know what's coming, even in 2022. Things could be very different in a year. So we have a small window to really move what we can, and let's focus on that.
Yeah. If it's okay, Julie, could I respond to just?
Yeah.
And then I just want to say that's another example where thoughtful activism mattered. We started to be aware of HIV criminalization laws and kind of their impacts about 10 years ago. And so we did first a collaboration with the Department of Justice where we analyzed all the laws and showed which ones, and wrote a paper together that showed how they were not aligned with science. And then also the Department of Justice sent a recommendation, a formal recommendation to all attorneys general to examine their laws and reform them. We then did an analysis that looked and said whether the laws made any difference in terms of HIV prevention, which was one of their purported purposes, and we're able to show through a model that they didn't. It did not help public health. And then recently I published with colleagues a commentary that under CDC's rubric that said, we can move beyond this. This is potentially harmful, and documented some of the circumstances, all with the idea of kind of providing within our role some of the response that could help some of the same work that you were doing. So I think it's another example of just kind of where that engagement has been positive, even though difficult. And I think maybe 10 years is also a very long time, but it takes a long time sometimes to get the work done. So I wanted to appreciate the community's engagement with CDC and other governmental agencies in this area.
Thank you. Thank you, both of you, for mentioning those. I think it brings us back to earlier points in the conversation where we just think about this really important, it's the dialogue we're having today, but it's part of this much longer, much larger dialogue, right, that's happening between the public players and the advocates, the people living with HIV, the folks in the people living with HIV networks. So I wanted to give Carl a chance to weigh in as well before, as we have a little bit more time, but partly, Carl, I was thinking that that question about capacity building for local health departments, state health departments, is so much an AIDS United question in many ways. And I wondered if you wanted to reflect, on that, but also on the idea of the bright spots and what you're seeing right now in terms of reasons for any optimism, even though we are still clearly in dark times too. So.
Yeah, so I'll address the question. I've got a mute. Got an echo.
You're okay.
Okay, I'll address the question. I don't know if I'll quite answer it, but take this opportunity for a little advocacy myself. The AIDS education and training centers are such an incredible resource for this sector. I think we've seen them being under-resourced by our federal government, particularly in the ending the epidemic initiatives that have rolled out so far. So in terms of training the workforce that is providing care and the next generation of providers, it's really critical that they be adequately resourced. And then in terms of bright spots, it is sad when we have to look for silver linings in this time. But, I think some of the innovations that CBOs and organizations across the country have made during COVID-19 are certainly a bright spot. I know that when talking to our members, innovations around and supporting folks who are disconnected physically from their communities they never plan to go back. We've heard obviously there's a strong concerted level of attention paid to people aging with HIV as that population, that cohort increases and is approaching retirement at increasing rates. The broadband access, the online and virtual support networks that have developed through COVID-19, I think those will stick around forever. And I think those models can carry out into other forms of the HIV care network.
Great, thank you so much. So I see that we're coming to our time. I want to thank all the panelists very much for joining us today. This dialogue has really been helpful to me, and I hope to others. I know that those of us here in FCAA are just grateful that you would come and spend the time with us, and we're always happy to have you. So I want to point out to people again, Kat's mentioned it in the chat, but there's an opportunity to reflect on key takeaways from this talk in what's called the Jamboard. And we'll be coming back to that toward the end of the summit tomorrow. And I don't want to forget to mention that at 4 o'clock Eastern, which is in another about 15 minutes, we're going to be having the FCAA kind of reunion, happy hour, cocktail hour. And I hope that folks will join us so we can do a proper send-off for John Barnes as he wraps up his tenure with FCAA. So we look forward to having you all join us. And again, thank you so much to all the panelists for being here, and look forward to seeing you in the rest of the summit. Have a good evening.